Welcome to another episode of Doctor, the award-winning radio show and podcast featuring your physician host, Dr. Tom McGovern.
And Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective. Doctor is brought to you in part by the generous underwriting of CMF Curo. Learn more at mycatholichealthcare.org and live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. Joining us from Portland, Oregon will be Dr. Saad Jazrawi. Saad is a gastroenterologist. He's a tummy doctor. He's going to talk about tummy troubles, digestive diseases, and everything else that can happen from stem to stern that doesn't go the way it's supposed to. So, Andrew, we really haven't covered this subject before, but we are now. Why might our listeners be interested?
I'm really excited myself. I always joke I'm passionate about colon health, and I think it's in all seriousness, but also it's kind of funny to say that. Everybody's got abdominal pain from time to time, and you wouldn't believe, Tom, maybe you would, the large number of people who have regularly occurring abdominal complaints, pain, of different varieties. And it's a bit of a mystery for a lot of folks where my belly hurts. Is it this? Is it that? How do we figure it out? And so it's one of the things I enjoy a lot, talking to patients about, helping patients with. But it is very challenging. And thank goodness we have GI specialists to help us sort out when you get down to it. It's like, okay, what's exactly causing this? But for listeners out there who have abdominal complaints, you're going to love this episode, and just know that there is hope and there is an answer. And you might stumble onto some information today to point you in the right direction.
So, as I like to point out to my children, much to their chagrin, topologically, human beings are donuts. There is a hole through the middle of us, all the way through, and you just can't see it, which is probably a good thing. But we're going to go on an all-expenses-paid tour through it, courtesy of Andrew here. So, Andrew, the digestive tract starts at the mouth. So what happens in the mouth that helps us to absorb nutrients?
Yeah. Well, first thing is you chew up your food. And it sounds easy. Like even little babies can do it most of the time. My kids chew their food. But the thing is it's not an easy process. There's a huge process to it, even in so far as forming a bolus of the food and getting ready to swallow it. Very complicated. There's a whole area of speech language pathology dedicated to helping people with problems here. And there's even enzymes that are released, namely amylase is the big one, to work with carbohydrates to start digesting your food even when it's in your mouth. We also get a little bit of the lipase as well to start digesting fats. But the biggest thing is getting it into a food bolus that is semi-solid that can be swallowed.
And then it goes through the pharynx, the back of the throat, and then down through the esophagus. So is the esophagus anything more than a tube that sends the food south?
Oh, yeah, I would say so. I mean, it obviously is the conduit, but it's a dynamic conduit. It's pulling the food down and pushing it down. And not only that, but also trying to keep the food down so that it doesn't come back up, which would be not a great day. It's a bad day.
In other words, it'll do the same thing if you're hanging upside down, won't it?
That it will. Isn't it amazing?
Yeah, it's so it doesn't care what way gravity says is down. It gets it to the stomach. So then what is happening in the stomach to get those nutrients where they belong?
Yeah, the first thing is we've got basically the lower esophageal sphincter where the esophagus meets the stomach. And it's kind of got two levels. There's an actual muscular sphincter that closes the esophagus to keep the food down, but then that is also right where your diaphragm, the muscle that helps you breathe, the diaphragm meets right there and forms just a small hole as well to keep your stomach down. All of these things obviously God designed to keep the food moving south as it's supposed to. And when you get to the stomach, not only do you have the food that you swallowed, but you have a lot of acid, hydrochloric acid, and that also breaks down the food as well. You can have a little bit of absorption of things in the stomach. Most of that happens later. It's mostly about using this hydrochloric acid to break down the food into smaller building blocks that'll be digested later.
And then the first section of the small intestine is met after the stomach empties. And that first part is called the duodenum. What special things are going on there?
Yeah, an awful lot. The duodenum or duodenum, some people say, it's about 20, 25 centimeters right off of the stomach, right as soon as you go through the pylorus. And basically, this is where all the chyme from the stomach, that partially digested, soupy food mix, kind of looks like a beef stew, in my opinion. That goes into the duodenum there, and that's also where we start getting enzymes. Most of the enzymes are made in the pancreas, and they come out of what we call the sphincter of Oddi. And that's not the only thing. We also get bile that comes out through this little hole and squirts into the duodenum, where basically it starts digesting on kind of a microscopic level these nutrients that we've ingested.
Well, then you've got the rest of the small intestine, which has two different segments. I don't know if there's a big difference, the jejunum and then the ileum. So what's happening in the jejunum and then the ileum?
Yeah, they perform basically very similar functions of absorption. Both of them, the ileum is actually about 3 meters long, and the jejunum's about 2.5 meters long or so. And the jejunum does most of the absorption. It absorbs sugars, amino acids, fatty acids. The ileum absorbs a little bit of those, but more bile acids and B12. So this is that small bowel, which when you add up the whole small bowel, we're looking at 3 to 5 meters. It's quite a long thing, but obviously it's wrapped back and forth, back and forth, back and forth into this big ball of bowel.
And then it empties into the colon, something that you get to look at frequently for your patient's health. What does the colon do?
Yeah, the main function of the colon is to get water out of the stool into the body again. Because you can imagine as you're drinking things, it goes in your stomach, that water's got to get absorbed. And then all of the stool products as well, when it's leaving the small bowel, it's very much a thin liquid, very thin liquid. And at the end of it, obviously, stool frequently is thicker than a liquid. And that process occurs by the water being drawn out through the colonic wall back into the body.
And the final segment, the anus.
That's right. That's a one-way sphincter, keeping things out that are out and letting things pass. And so that's basically kind of the top to bottom. We also should give an honorable mention to the appendix, which is right where the small and large bowels meet. And lots of hypotheses about the appendix, if it's kind of a remnant of something that we used to use and we don't use anymore. I've also seen a hypothesis out there that this is where good bacteria kind of can be stored, even if you have, say, a bad bout of diarrhea and everything gets wiped
Ah,
out. You've got a little bit of good bacteria hiding down here that can come out and recolonize. And the appendix is like a very small sock sticking off the wall of the colon at the cecum. Looks totally useless. A lot of people don't have them, but the theory is it probably performs some function that we don't completely understand. So, always more to learn.
Andrew, that was just as much as a trip would have been in the magic school bus with Miss Frizzle, which now takes us to our medical trivia question category of the day, which is gastrointestinal etymology. Yeah, I just lie awake at night with the opportunity to say those two words online, gastrointestinal etymology. And so the question, one part of the intestine is named after the Latin number 12. What part is it, and what does the number 12 have to do with it? We'll get to that at the end of the show. But before that, we'll have Saad Jazrawi on with gastrointestinal common problem. Welcome back to Dr. Doctor. We have with us now Dr. Saad Jazrawi. He received his medical school training originally in Baghdad, Iraq, then completed more medical training in Oregon, New York, and Texas. He then specialized in interventional gastroenterology with a focus on pancreas and bile disease, as well as digestive cancer treatment and staging. He joined the faculty of Oregon Health Sciences University as an assistant professor. He's a cradle Catholic and grew up in the Eastern Chaldean Rite. He's currently president of the Portland Guild of the Catholic Medical Association in Oregon, and he tries to combine his faith and his work to be a better Catholic and physician. And when not working, he likes spending time with his wife, Grace, and his 4-year-old and 1-year-old children. Saad, welcome back to Dr. Doctor.
Thank you. Thanks, Tom. Thanks, Andrew. Good to see you guys.
So, the digestive system. Yep. What was it about the digestive system that intrigued you so much that you decided to devote your professional life to it?
Uh, it started the first time I was doing research in Oregon at the time and about liver disease, and I was fascinated about hepatitis C at the time and the intellectual approach to medical to the many of the liver diseases. So it's like, I love that field, and I looked at the
Ah,
people who were doing this specialty, and they were all happy and excited, and it brings energy. It's like, I want to do this specialty. I want to be this person, 10 years later. So kind of, and then the
oh.
journey. Yeah, nobody told me it's actually a little bit longer than that, but it worked out to be a very good choice, and I'm very happy about it.
Man, that's great. What gives you the most joy when you're caring for patients with GI problems?
Spending time with patients. I mean, despite the fact that my specialty is a very tool and a technology driven. I mean, it's like, if you like video games, this is the specialty that is the next in line for medicine,
So
because it's
next
always
level.
it's it could be the next level. It's basically trying to go with a scope into the end of the colon or into the small bowel, into the biliary duct. You're looking for targets, and you're either sampling them or removing them. So it's a lot of hands working, a lot of technical things you use. So that's kind of the fun. Then you have the intriguing, the intellectual part, which is talking to the patients, trying to solve a problem that does not have a physically easy diagnosable thing. Uh, so that's sometimes the fun part to me, is, as much as I enjoy the technical part, I enjoy talking to the patients a lot.
Now,
How
Saad, I
come do you
remember.
think Nintendo has not come out with a colonoscopy video game yet? I
Uh,
I
as
don't understand why they haven't done that.
As a disclaimer, when I was early in my training, I struggled a little bit in scoping. It's like, and my boss says, buy a video game. So I bought a video game, and I wasn't used to be playing that much. So it's like, I played video game, just kind of just teaches eye-hand coordination, and I got better a lot after that.
Now, I remember in medical school, one of the funnest acronyms I learned was ERCP,
Yeah.
endoscopic retrograde cholangiopancreatogram. What's even more amazing is what it stands for. Explain to the audience what that is. I mean, that's just insane that it can even be done.
Yeah, no, I mean, the normal function of the pancreas and bile duct is basically, I'm going to use the word dump, or put pancreatic and liver secretion enzymes into the digestive system, and that's how they connect through a pinhole opening. So what we do is retrograde, which means going backward into those ducts, trying to solve a problem, and it's
But you
called.
have to go down through the mouth to get there.
Yeah, so that's when the
I mean, explain.
endoscopic, which is, so go with a camera through the mouth into the stomach, into the small bowel, and that's the pinhole of the emptying of the pancreas and bile duct, is into that opening, into that lumen. And when we see that opening, and then we try, and it's, by the way, the camera does not have when you go, you don't see in front of you, you see on the side of you, because that's where the hole is, on the side. So it takes a lot of
Ah,
training to finally be able to get there, but once you get there, you put the access. So that's where the endoscopic, the E, retrograde, is going backward, and then either pancreas or the cholangio, which is the bile duct exam. It's the best way to examine those organs, because any other way, which is, you would think going the antigrade would be the best, which is the normal path. Actually, it is means they have to poke them from outside, penetrate the liver capsule, and then get into the bile duct, uh, uh, or you try to get it through the pancreas, which is a lot harder.
wow. So we're a Catholic show. There's passages in the Bible about just about everything. Is there anything you like that the Bible has to say about the digestive system?
So this is a little bit more of like, I kept thinking about that, and I found the passage from First Timothy 5:23. It says, "Drink no longer water, but use little wine for the stomach's sake, and thine of infirmities." It's basically St. Paul telling Timothy. I would just say, instead of wine, maybe cognac, and not in excess, could be a good therapy for anything you want. It's a tough one. I have to prepare next time a little bit better than that, but it's the best thing. I can advise that. Okay.
Very good.
Can you walk through? You had mentioned GI is a technical specialty, so many different tools. Can you talk to us a little bit about the general tools you would use, scopes and whatnot?
Yeah, yeah. So I was thinking about that. How could I describe a GI to the layperson, and what would I tell them with the scope sizes and the thing? And the best way I can think about it is, um, the way, you have like your kitchen tools. You have different sizes of pans, different sizes of forks, and different. So we have that, and it's in principle they're all the same. It's a camera connected with fiber optics, all the way connects to the scope, which has a handle, turns it, magnificently. The Japanese perfected that science. So the best two or three companies, actually, all of them are Japanese companies.
Mm.
And Olympus is the most known. But so you move the dials, and the tip of the scope changes direction, and then you advance it into the digestive system. It's a long track. It's a very long track, actually, and but the thank God the most common problems we have are within the reach. It's within the first,
Mm.
2 feet on the upper digestive, and in the lowest side, the most distal 3 feet. With those scopes we can easily get those. The remaining, 20 feet in between them is hard access. We do access it, but most of the times is a lot less commonly needed to do.
So, how often will you use an imaging study like a radiology test as opposed to using a scope?
Well, it depends on the things, and sometimes some of our problems needs imaging. Some of the imaging needs eventually advocates for us to do scoping. So
Mhm.
in general, I would say 50-50. But a lot of our patients, by the time, and especially what I do is more of a pancreatobiliary work. A lot of my patients already if they don't have imaging, I can order imaging. So almost 100% of my patients going to have imaging, and when they come to see me, it means they're going to need to have more intervention, like endoscopically, in
How nervous
ERCP.
or anxious are patients before they have a scope done, and what do you do to help calm them down?
There are two categories of patients I deal with. One of them is the regular screening colonoscopy, and that is they want a clean bill of health. And the most of the times, the patients have either reached out and looked into the internet for something, and they are more anxious, or they are, kind of, by the time they've seen it, they've talked to their neighbor and they reassure them. But most of the times it's a very good conversation. It's very easy to explain. I usually try to break the ice with some, small comments here and there, and try to build a relationship, because it's a very fast paced work. So that's for the
Mhm.
regular endoscopy, or regular colonoscopy. Uh, but the anxiety is mostly by building a relationship with that patient, even on a short period, and allow them to ask questions, and comfort them. The harder one is the what I do more on my work, which is the pancreatobiliary, which is examination of the pancreas and the bile duct. And those patients are more of a long, you know either chronic problems do they have, or actually they're sick, with rule out pancreatic cancer, or rule out anything more serious. That group is a harder, I definitely want to advocate as much time to explain to them the procedure, give them some comfort, and build a rapport, because sometimes I'm going to have to call them back down the line to explain to them the results, that which always is more complicated.
So, one of the things we want to do in this show is we want to get into common GI problems. And I get to work in family medicine. I feel like we're talking about GI problems all the time, saying like, "Hey, we've got to get you to a GI specialist." Say, for example, the one that I feel like I hear a lot, abdominal pain. My belly hurts. How
Yeah.
do you work that up?
So it depends on who sends you. Primary care is the easier one. Usually, it's by the ER. By the time they come in, they already have the CAT scan. A lot of our work cut off for us, and it has to be scoped. But somebody with abdominal pain, it's a lot of the information. So if somebody comes in and like if I'm going to buy something and somebody knew I'm a doctor, say, "Hey, let me ask you about abdominal pain. What would I do about that?" And my two important questions, easy to I wouldn't say 100%, but it's like the easy to rule out. I say, does it get worse with eating? Does it get better or worse or better on eating? Worse or better with bowel movement? If neither of those, you're 95% less likely to be digestive. Not 100%, because there's always something that is nagging pain, has nothing to do with that, including pancreatic cancer sometimes has nothing to do with eating or bowel movement. That said, those two questions, the first two, you just rule out the digestive symptom relationship to it. That's one easy one. Then we start to
So
work
that
out.
way, so I understand this. That means if pain does not get better or worse with eating or a bowel movement, it's probably not a serious problem, or it's probably not related to the digestive system, or both.
It's probably not related to the digestive. I would worry more about, I mean, because we get to see patients with back pain, referred
Right.
to the
Mm.
to the kidney problems affecting the digestive, affects the belly pain. It's the myriad of things. Yeah, and once the we kind of think the abdominal pain is related to a digestive system, then we start to try to rule out other, where how do we approach them? If the symptoms are related to eating, nausea, and vomiting, then it's mostly an upper digestive. If I was a primary care, or in the first line of seeing the patients, I'd rather make sure first a trial of acid suppression could help. It helps to relieve, and avoid sending patients that they don't need to be seen. Um, Sometimes imaging could be needed, especially if there is some concern of weight loss, or on the older age group patients. I start to worry about something more serious, or if they have anemia, we may not need imaging, but they need to see somebody in the specialty. And the lower digestive, it starts to be associated with bowel movement issues. Again, they still going to need to see a digestive specialist or a GI. I think before that, if the easy approach for most problems, try fiber. If you have a loose bowel movement, try fiber. If you have a hard bowel movement, try fiber. I mean, whatever you do, it's fiber. The solution for actually most digestive problems get solved with fiber. And for those, I mean, mostly irritable bowel syndrome. Not everybody can tolerate fiber, so again, at least a reasonable percentage, a decent percentage, will be solved with fiber and Pepsid or omeprazole.
Okay, so Saad, you gave a ton of pearls within there. I just want to unpack it for people that aren't used to listening to medical information so much. Upper GI problem, first thing to try at home if pain's getting worse with eating is acid suppression. Reduce the acid getting from the stomach up into the esophagus. Is that right? And
From the
how can
stomach
they
to the
do that?
esophagus. Yeah.
How can they do that over the counter?
I would say Pepsi. I would just caution people. It's like, you don't just like, oh, I took it and it felt well, and let's stay on it. Generally speaking, the recommendation now is like 2 weeks trial, and I would try not even omeprazole, try Pepsid. Omeprazole, a little bit stronger medication. It's pretty safe, but if you start to feel well, there are, in my calculation, there are things I wouldn't just treat it blindly. I would may want to do further digging, and these comes into these in the approach, and your primary care provider will know that. I would know that, but as a layperson, probably try Pepsid for 2 weeks. Happens many times. People get too much acidity for a reason or another, whether it's stress or whether it is, got, reflux acidity. And once it happens, it takes, about 5-7 days to get better. So, in the meantime, you either want to sit and suffer or take the Pepsid and you start still feel better, then get out and go about life. But generally speaking, that's usually the approach. The things to not to do if you start to see vomiting blood, if you're, black stool, like we call signs of bleeding, or if there are weight loss that we can't explain, just talk to your primary doctor.
So, when you're talking about acid suppression, we're trying to turn down the acid. Mainly, they're trying to treat like too much acid or reflux, right?
What happens during stress? When I'm stressed, I increase acid secretion. Stomach acidity is usually about, it could drop to 2 during eating, after soon after eating. So the acidity, and that's what breaks down food. It helps to breaks down food by secretion, by chemical breakage. And then there is the mechanical, which is the stomach. What it does, it churns until it breaks it down into tiny, tiny, small uh, pieces. Uh, Acid is what helps in that process. You don't have to have 100% acidity to make it work. You can slow down the acidity. So if you take Pepsid, you can probably get the acidity down to 3 instead of 2, or four out of instead of 2. What happens in terms of reflux is when you eat, so the the esophagus seals itself against the stomach, it protects itself. But the problem, each time you eat, it leaks acid up. And when
Mm.
that does, it causes injury. And if that area is raw from, from being under stress and other things, it starts to continue to get worse and worse. And breaking that acid, secretion a little bit, it'll decrease the amount of acid coming back to the stomach each time you swallow. You could be swallowing saliva, it could happen. So there's a lot of things that could be even incidental. But the problem is when it's stressed, it could become more painful.
And then,
People use terms like acid reflux or heartburn or GERD kind of interchangeably. What are the difference between those things, and how do you think of them?
So just gonna backtrack 1 second here. Actually, two things that comes to mind. One, in acid, first, heartburn is the most common symptom. Almost, I forgot, like that one time, it's like 30% of the population have it on a monthly basis. So
wow.
it's
Wow.
the most common symptom, and it's a feeling of a heartburn or feel of food coming up into the esophagus or to the throat. That's the reflux. Now the we call it GERD, if for those, and that's if it has inflammation with it. There's a lot of patients will have no inflammation even when you go there. Like, people have a real reflux, and there are other ways to test for that. We call it pH testing, other ways. And but you go there and it looks as pristine as a normal person, and it's like, well, I still have the pain. And you do the additional testing, which is motility or a pH testing, and then you can see actually acid or even alkaline. Sometimes too much alkaline goes up into the esophagus and
Hmm.
causes injury in that area. And it is usually a patient has a mark, like a pointer that they could point, and actually each time they click their device is the time when the acid or the alkaline going there. So um, there are two types, which is the as GERD, which is with the inflammation, and without the inflammation. So sometimes even without it, they still benefit from the treatment, which is the Pepsid. That's why try Pepsid first. If it works, you avoid the seeing a gastroenterologist.
And then the other end, you said take fiber. How much for how long before you see your doctor?
Okay, so the Western diet is, so there's things we do in our Western world that we unfortunately contribute to our I would say digestive problems, and it's a very common problem, which is decrease motility. Our mobility is decreased, so we need to be mobile to have a bowel movement. We need to drink water enough, a large amount, to allow us to have a bowel movement, because you have to realize 99% of the water we drink is still going to be reabsorbed. So I'm not saying that you have to, but you have to have something to allow the bowel movement to pass, the content of the stool to pass. And thirdly, you have to have something that stays in. If I eat chocolate, protein, and carbohydrates, the digested carbohydrates, and I will have no bowel movement. I will have only sloughed mucosa coming out. The reason is, I mean, but that's going to take forever to pass. So it takes forever. So what you do, you need fiber, the undigested carbohydrate, which is the fiber, will eventually pass the digestive. It works as like the carrier, the train that carries the materials we don't like, sometimes unwanted fats, toxins. It takes it with it as it passes the digestive system. You will need about 30 grams a day. But I would say anything above 20 grams is great. I hear people like, well, I'm a vegan. It's like, yes, but you're eating, things that doesn't have enough fiber. You're eating called vegetarian, but you're eating things that does not have enough fiber. I think the best source of fiber is green uncooked lettuce and anything uncooked greens. Broccoli is great, but there's a lot of other sources of fiber. It's not just that. I mean, but in general, eat 30 grams. How do we know if you are eating enough, and whether I say trial, add, get the I mean, I'm sorry using Olympus and Metamucil, all these companies' names, but but try something that has fiber. But Metamucil would be a good source, one of the brands. But any fiber, and try a couple, for 2 to 3 weeks. Unlike Pepsid, which works fast within a day or two, fiber, it takes about a month to really balance itself into the digestive system. And that's one of the biggest, we try to sell this to the patients. Like, whatever you do, don't start fast, because you really don't know. It's like the downstream, it takes 2 or 3 days to show itself. So by the time you're just like, well, 3 days, nothing happened, increase this, like, oh, then now you're going to have over, and all of a sudden you back away fast, and we run into this seesaw effect. So slower is better, and be patient.
This is great information, and we're going to have more of it after the break here on Dr. Doctor.
And we are back today on Dr. Doctor, and we're talking about the GI tract. Saad, can you maybe just tell us, what are some healthy eating habits for GI health?
I think we cover I can think of the lower digestive system is pretty good. I think the upper digestive is for what can we do, and what do I advise my patients? A few things to as a disclaimer, lifestyle modification works only so far in the reflux. And what it means, you could do only so much. Unfortunately, you're still going to need a medication to buy you time. For reflux, for those who have persistent reflux, or either despite medication, or they don't want to take medication, can they get by not? I would say one of the things you do, don't take too much juices. Juices are high in acids. Acids eventually stays in the stomach, stimulates more. It's a recipe for more acidity. Acid reflux causes more. Eventually, it goes from the stomach periodically into the esophagus, causes the symptom of heartburn and pain.
What about apple cider vinegar for reflux?
I've heard people do that. I have no. Some people swear by it. I've seen their esophagus looks bad, so I'd say no. Don't do that.
Okay.
Yeah.
Fair enough. Is there anything we can do about when we eat, or what types of foods to avoid?
And then that's a good question, actually. The other thing is, I don't know where intermittent fasting does. I don't have data to tell whether it decreases. I'll bet it probably could help more, just because you have a long period of not things escapes from, because if we nibble a lot, you're allowing more. Each time you swallow, basically, is an opportunity for contents from the stomach to leak back to the esophagus, and every time that happens is an acidity injury. Some esophagus will never have a problem, but some will have a problem. And
so will you have just as much problem if it's a cracker versus water? In other words, does just drinking water affect the reflux?
Absolutely. Actually, what I tell people is stop chewing gums, because chewing gums, what they're doing is actually they're putting saliva, and each time you're unknowingly swallowing saliva is an acidity coming up. And that's what
Mm.
sometimes people say, well, when I take Tums, it feels great. It's like, yes, but what it does, Tums goes in every time you're doing that, and they chew comes one after the other. But the problem is each time you're swallowing, you think you're washing it out, but then acid comes back again, and then it feeds it into. So it works for simple things, not big problems or not big problems, just any mucosal injury, you'll need something stronger. So eating with maybe a longer interval between foods, and longer interval between eating and go on a recliner and go in bed, because if people who eat late and go to bed are guaranteed to have reflux. Will they feel it? Not everybody, but some people will feel it. So for those who have symptoms of reflux, it's like, don't eat and go sleep immediately, or recline, because
How
that's
many
opportunity.
hours in between is best?
Minimum two, but
Okay.
and I don't do that. I mean, I finish my late day late, and I'm eating, and I go crash immediately. But when things are not working out well, I'm definitely making those 2 hours, and better is four. I mean, I know people who eat before 6, and they'll sleep at 10. It's like, that's and it worked out. I mean, they may stay away from medication because of that. Weight reduction helps. The other thing that they could be doing, I think, avoiding alcoholic beverages, avoiding especially wine. I mean, as much as wine, talked about the benefits, wine is increased acidity, caffeine increase acidity, and peppermint. It does not increase acidity, but what it does, it decreases the tight gastroesophageal junction, so it loosens, and actually what it does basically allows acid to come back and cause more injury.
Okay, so let's talk about a common problem that parents see in their children that even adults might have, and that's diarrhea. How should somebody, well, first of all, what is diarrhea versus just a loose stool? And what should people do about it? When should they see a doctor? What should they try before seeing a doctor?
Well, I mean, so diarrhea is less commonly I see. When we see them, it's a bigger problem because we're
Right.
talking about inflammatory bowel disease and things like that. But if you're an average, a layperson, and get a diarrhea, if it's a 1 day, I wouldn't worry about it. Or what's a diarrhea? It's I remember it used to be 500 grams or more than 3 bowel movements, and and that's what I usually tell patients. Nobody weighs their weight, well, bowel movement. That's fine, but I was so I was like, how many bowel movements? Because if people define things differently, constipation also the same thing. So it's like, what do you mean by that? And actually, most symptoms, and try to decipher the misnomer things, because
Right.
then we're addressing the right problem. So but if they have multiple bowel movements for 1 day, hey, you could be ate something and it's gone. If somebody says, well, I have months and months of diarrhea, then I worry about it. At least do some basic investigative. It could be a blood test, it could be stool testing. Somebody says, you know what, go ahead.
Is
I
there
was
anything over the counter for diarrhea? People always talk about Imodium, but would you recommend that for people to try?
so I've done missions, and when traveling, I take a chunk of Pepto Bismol. Again, I'm advocating companies, but it works magic. It has an antibacterial effect. It has anti-nausea effect, and it's great. You take it out and try some Pepto Bismol if that's really bothering you, the diarrhea. A couple of days, 2 days, not more. If it continues, then yeah, seek something. Just a disclaimer: this Pepto-Bismol, change the stool black. So if somebody takes it, be careful. If you see stool black, it's nothing bad. It's just it's the Pepto-Bismol working. Um, but that's one good thing. Probiotics are amazing.
Oh, yes.
Uh,
Yes.
we killed all these bacteria in our gut. We in the where I grew up, and in many countries in the world, the yogurt has a lot of bacteria. We in the sake of protection and cleanliness, we pasteurized everything and killed any bug could be growing in the yogurt. One option is we've been adding probiotics, and those work actually. They do help. So people who have diarrhea, imbalance of gut symptoms, bloating is a big deal. Try probiotics. Works in like a charm. And which one is best? This one, I really don't have a solution for that because there's so many brands. Most, it's not most, they are not regulated by the FDA. So trial of error, and if this one works, stay with it. How much do you try? Try, let's say, 1 month supply, so you know. But if it works, stick with it. I mean, um, just don't buy the most expensive. That's the thing
A,
also.
a, a lot of people that I know like to take probiotics almost like a multivitamin just for health. Is that a good idea or not necessary?
I don't. It might be unnecessary if they don't have symptoms of digestive imbalance. IBS is a very common disease, so if they have irritable bowel syndrome, yes, they need to. But if not, it's. I again, I say don't put your retirement in buying all these. And many of those probiotics. It says 20 billion of bacteria, but who measured it and who says it's going to survive the acidity of the stomach is going to kill. I mean, that's what the point of the acidity of the stomach kills any bug it goes into there. So I'm not I think it helps, especially for patients with irritable bowel syndrome, especially, but I wouldn't go into religiously pursuing that because it's not. I mean, you actually take me to another topic, which is the microbiome, which is, again, that could be another 5-hour conversation, and we don't know where we're going. But they're finding out the bacterial composition of your digestive system could contribute to your obesity, you know, your depression and anxiety and other things. And but the science is so new on this, so we need many years of work to know where we're going with there.
Well, speaking of microbiome, way back when I was in medical school, I did research on something that was then called Campylobacter pylori, then discovered to be Helicobacter pylori. There's actually a bacterium that can live in your stomach in that pH. And does it contribute to ulcers or reflux?
So H. pylori, it's actually a carcinogenic. It's a very the person who I think William Marshall, who discovered it
Barry Marshall.
in
Barry
yeah,
Marshall.
Barry Marshall.
I
Thank
met
you.
him at a conference. Yes.
Yes, and the way he discovered it, he found it, and he had to swallow the bacteria and developed an ulcer, and that's how they found that is the. He got a Nobel Prize for that. The but the
Yeah.
idea, the idea behind that is stomach cancer was one of the most common cancers worldwide, and finding a solution, a curable disease, like a revolutionary. We don't have it as common in the United States, but it does happen. It's a bacteria that grows in that resides in water reservoir. So if you travel international, I have actually recently patient who continues to travel and to third world countries as a missionary. But the problem is each time he goes, he gets a H. pylori, comes back, and we treat him, and that's the second or third time. So it's like,
Oh
take your
wow.
bottle with you. If you take a bottle of water, you're protected. Bottled water is not going to be at the place. I mean, I hope. So it is known to cause ulceration, and even if you treat the ulcer with acid suppression, that chronic inflammation is eventually, and it does work in it creates an carcinogenic chemical at the level of the mucosa that eventually they develop gastric cancer. It is
Wow.
not common, to clarify, it is not common in the United States. I still get a lot of patients diagnosed with it, either from being traveling abroad or born abroad, or maybe lived in a very unsanitary world place at some point in their life. But it is not common. I don't want to send the message out there that it is the reason. Again, one in, I don't know, 50, in 1 in 100 endoscopy, I probably see one with
And,
infection.
and so, what's the relationship between H. pylori and ulcers, stomach ulcers?
What it does, it changes the chemical, breaks the mucosa at the area, and eventually
Mm.
once it breaks, it becomes basically
What
chronic. So
percent of ulcers are due to H. pylori?
in the United States, oh, it's a very small. So
Okay.
let me the ulcer. So the stomach is again. It's kind of it's our body is created in a beautiful way if we look at it from science and creation. It Stomach secretes acidity down to below 2, sometimes the pH. But what it does, the lining of the stomach is protected from protected from what's inside the stomach by a thin or a thick layer, you can call it, of a mucus, very thick mucus. That layer of mucus is what protects the stomach. On the other hand, if they have H. pylori, that mucosa, that layer of mucus is broken, and that's how the stomach ulcers develop, because they break in the mucosa
But how do
of
most
the.
ulcers develop if it's not due to H. pylori?
It happens because on most of the times, and there are two, I think I can think of, common causes: stress, and who's not stressed, but stress and how your body responds to stress, and taking non-steroidal anti-inflammatory drugs.
Mm.
Alcohol, I would say, number three, and heavy alcoholism is another cause. And non-steroidal, what it does also, mucosal injury. It causes local ischemic injury and eventually ulceration.
Man, I love it. There's so much stuff to talk about. It's tough to know where else to dive. I know we talked a little bit about diarrhea. The flip side of that is constipation. Maybe you could tell us a bit about that. And starting off with, what is constipation? Because a lot of people might use that term differently.
Oh, the same thing. Well, this one, thankfully, they don't have to weigh, but it says one bowel movement every 3 days. Uh, it's and most patients, sometimes they use the word to describe difficulty passing bowel movement, and that is not a constipation. But it's this I kind of, it guides me into the fact that either they're not drinking enough water, that either they are not having enough fiber. But I don't want to say that is the only reason. There are so many other reasons that you could develop constipation. Sometimes patients with diabetes could develop the constipation. Same thing, patients with thyroid problems could develop constipation. Sometimes, actually, tumors could be causing, we call a pseudo obstruction, but
Oh,
and
sure.
basically, yeah. So it's called pseudo diarrhea. It feels like your patient either have a diarrhea or have constipation. Actually, it's an obstruction by a tumor. So there
Mm.
are other causes. And the other thing is the digestive system throughout our life changes motility. And some people say, you know what, I used to be good and now I don't have a good balance. Like, and it's like your knee. My knees work well, but at some point it starts going to have, dysfunctional issues. And and sometimes you need my glasses. I mean, I'm wearing contact today, and with at some point my glasses were great, and then all of a sudden now it doesn't work as good because it's wear and tear. And now what you need, a little bit of fiber, more water than you used to, and maybe walking. But if doing that, sometimes that solves most of the problem. There are other reasons for that. It takes more digging to find what it is. A lot of times you can do some basic panels of calcium and thyroid function and things like that to make sure we're not missing some easy reversible things. And then we can dig deeper into, motility dysfunction, and that could be a big can of worm.
And then something that I've heard before is that the char on top of barbecued food is making us more at risk for colon cancer. What do you know about that, Saad?
It's actually, red meat itself is a risk for colon cancer. That said, I eat red meat. I'm a sucker for for barbecue. It's the easiest thing that I could help my wife and so I enjoy it. And I'd say yes, it could be harmful. That is absolutely, there's been studies to show that. But again, I
What's the
think if
absolute risk? How big is the absolute risk?
I'm not sure if I know that, to be honest with you. I'm sure somebody has done something and published it, but I'm not sure. It's been kind of, since I was in medical school, so it's been a while. It's been known to be that. That said, people still eat barbecue. I think the most important thing I say, if you see, I mean, if you're cooking and you always have to just clean up your barbecue periodically, maybe once a year, once, it depends how much you cook, but just to make sure you don't have too much charring attached, because I don't think it's healthy anyway. And it could be something else. It could be the red meat itself. It could be anything else. But I compensate by going for a run after that. That should be fine.
Good man. Well, thank you for a fun tour through the digestive system. This was a chock full of practical advice for our patients. I think we'll probably have you on again, Saad. Thank you so much.
Thanks, Tom. Thanks, Andrew.
And we are back with Dr. Doctor, and the answer to the trivia question, and who other than Dr. Tom McGovern, homeschooling father that he is going to give us etymology that's related to the gastrointestinal system. I always say, people feel like it's all Greek to me, but I think you're going to give us some Latin etymology, right, Tom?
Yes, Andrew, I am. And the answer, I tried to kind of cue up the answer if you were listening carefully in the first segment, because I pronounced a word differently than the way Andrew did to try to give you a hint. And so the question is, one part of the intestine is named after the Latin word for the number 12. What part is it? It's the duodenum. So like a duodecagon has 12 sides. So the duodenum or duodenum was identified back in, gosh, how long was this? Let's see, the 14th century, because it was about the length of the width of 12 fingers. It was a width of 12 fingers long, and thus given the name.
Sounds like the
actually,
same
since
people
you're
who
the
came
Greek,
up with horse measurements. They always measure horses and how many
yeah.
hands. Like, what were these people doing?
They were using parts of the body. They were using their ruler that they were carrying around with them, their body.
12 fingers.
And I think a cubit, back in Egyptian time, was the length of the pharaoh from his elbow to the tip of his middle finger was a cubit.
Ah, there you go.
And the English foot at the time would have been the length of the foot of the king. I might be making this up, and we can have somebody call in and tell us the right answer to this. But there you go. Duodenum, number 12. Andrew, you've got top three takeaways.
Oh, I do. It was hard to narrow it down. I would say, as it relates to the GI tract, number one, he brought up a really good point to try and figure out, is this a GI problem? Most of them are going to be related to eating or stooling. It might get better or get worse if you eat or have a bowel movement. So that'd be number one as far as, is this GI related? Number two, he said, kind of just general health principles, more fiber and more water. And good sources of dietary fiber, he said, is uncooked green veggies. I'm talking about salads, broccoli, or things that he mentioned. And then more water. How much is too much? Hard to do. More water. And then number three, he had some really good practical tips. If people have symptoms of the upper GI tract, kind of nausea, or heartburn, he said, go ahead and try some Pepcid over the counter for a couple of days or a week. If it goes on more than that, you want to go seek out care. And then he mentioned for diarrhea, he recommended trying some probiotics for a couple of days. And if it lasts for a day or two, no problem. But anything that's going on for a long period of time, you definitely want to seek out care because it could be something more serious.
Yep, full of practical advice. You might have to listen to it a second time to get all the pearls. And thank you for listening to this episode of Dr. Doctor. You can find this and all our old episodes on our website, drdoctor.org. Just click on episode archive at the top and you can search over 300 episodes by topic or guest.
And we now have a YouTube link near the top of our homepage at drdoctor.org where you can see the video version of our podcast. While you're there, also click on Submit a Question if you have a question for us or an idea for a great future episode.
This is Dr. Tom McGovern.
And I'm Dr. Andrew Mullally, and we're signing off until your next dose of Dr. Doctor.